what does it actually take to make that diagnosis? I'm going to answer that question today. Broadly, the disease can be diagnosed clinically, it can be immunologically diagnosed, or it can be genetically diagnosed using molecular biology. In clinical diagnosis, we're basically using CT scans to look for telltale signs of COVID-19 pneumonia in patients and using clinical judgment, typically based on expert radiologist opinion. In immunological diagnosis, we're basically trying to detect antibodies or antigens in the blood. And in genetic diagnosis, we're basically looking for specific gene sequences that are unique to the virus as detected in biological specimens, such as nasal swabs or sputum. As you can imagine, each of these approaches to diagnosis have weaknesses based on what they require and on the inherent methods. So I'll go through each one in more detail and discuss the ramifications for detecting the virus that causes COVID-19. So the first thing I'll talk about is immunological diagnosis. Basically, what we're looking for here are the antigens, in some cases the antibodies, and we can use the body's antibodies to bind to the virus's antigens. So an immunological assay requires a blood sample, because what we're detecting in the blood is an antibody or an antigen that's specific to the virus. And one major disadvantage, of course, is that you have to wait until the body mounts an immune response to the virus before you can actually detect that antibody. So that's one disadvantage. And it's also the case, the next option we have for diagnosing COVID-19 is genetic testing. Here, we take some kind of tissue sample, such as a nasal swab, a throat swab, or some sputum. In that sample, we're looking for the virus's RNA. To do that, we use a method called PCR, or polymerase chain reaction, and this is simply a method that allows us to copy and amplify any piece of DNA so that we can detect it, even if there's a small amount. Remember, we took a tissue sample, and so our human DNA is going to be most of that sample, and hopefully the virus is only a small portion of the sample, and we need to amplify that small virus portion. And you've probably heard this term PCR many times, as people have talked about testing positive for the virus using PCR, because it is by far the main way we're able to diagnose the disease right now. Now, specifically for the SARS-CoV-2 virus and any virus, we have to do a step before PCR called reverse transcript. This is because a virus is RNA, which has a single strand, and PCR detects DNA, which is a double strand. So the reverse transcription process basically converts virus RNA to DNA so that it can be amplified using PCR. And so that's why you see this RT-PCR as the method for detection for COVID-19. And actually, what we're amplifying is a specific sequence in the virus RNA. So nowadays, we can do genetic sequencing very quickly. We can know the order of the nucleotides, and that can be uploaded to a database and shared via the internet very quickly. And this is what has allowed us to quickly identify specific genetic fingerprints of the novel coronavirus and be able to roll out this type of test very quickly. And then we use spectrophlorimetry to measure that sequence of DNA that we amplified. So basically, we're looking for a specific sequence of the virus RNA in our sample. We use reverse transcription to convert that RNA to DNA. We use PCR to amplify that converted DNA. Then we use fluorescence to make that converted DNA shine, so to say, and we measure how strong the optical signal is. So the more genetic material that we detect, the more virus that was present in the sample. Now, the obvious advantage to this diagnostic approach is that it can be done very quickly after the virus has been identified. There are a few disadvantages, though. First, the virus needs to be in the sample. We use RT-PCR to amplify the virus's genetic material. So if the virus isn't in the sample, nothing will be amplified or found. This makes sampling very crucial. Being a lower respiratory virus, COVID-19 is not found in high concentrations in the nasal area, yet nasal swabs are often used. Even throat swabs can come back without any virus in them, even if the virus is present elsewhere in the patient. In addition to the choice of nasal or throat swabs, the actual collection is really critical. An improperly trained nurse or an uncooperative patient can mean that the swab didn't collect enough tissue. A second disadvantage is that the virus must remain viable during transport. Most countries around the world are limiting the labs that they approve to do this procedure. Therefore, samples must be packaged and shipped to the performing lab. If not packaged correctly or delivered in a timely manner, the virus DNA may no longer be viable and the test won't be able to detect it. And a third disadvantage is that there are many different protocols being used. In fact, each country and each test is in many cases targeting different sequences of the gene in the virus. And the problem here is that those results could be less comparable between countries and between labs. The third option for diagnosing COVID-19 is to do a clinical diagnosis. We usually use a CT scan of the lungs. In this case, we aren't taking any samples, but we're doing some imaging and assessment by the physician. In China, they've shown that CT scans are a really good way to look for the telltale signs of COVID-19 in the lungs, and they can make a pretty good clinical diagnosis this way without having to wait for laboratory results, especially in cases where there's a large number of patients in a widespread epidemic situation. So a big advantage is that clinical diagnosis is faster. No need to wait for the lab results. Another advantage, it turns out, is that it can have a very good sensitivity. Sensitivity is basically how often you get the diagnosis right. I'll show you research that shows that clinical diagnosis actually had higher sensitivity than RT-PCR tests. A disadvantage is that there isn't that feeling of a definitive certainty that comes with a test. What I would say, though, is that it would be pretty obvious that you've got viral pneumonia. So whether it's flu or COVID-19 doesn't really matter too much because the therapeutics aren't very different: rest, fluids, and antivirals. So that's not that big of a factor in my opinion. Of course, you also do need to have well-trained and experienced radiologists. So how do these methods compare? Remember, immunological diagnosis isn't really a widespread option yet. So for the most part, we're comparing testing using RT-PCR to clinical diagnosis using CT scans. Looking at more than 1,000 patients, a study published in the journal Radiology showed better sensitivity in CT scans compared to RT-PCR results. This has to do with the issues I raised earlier with RT-PCR. You can very easily miss the virus, which is why PCR diagnosis has a sensitivity around 60%, or as low as 60% it's been reported. That means we could be missing up to 40% of infected people when we analyze using PCR. So, what is Thailand doing? Well, like much of the world, Thailand is using PCR. It's really the best option we have at the moment. However, the number of labs authorized to do the analysis is fairly limited. So I think this limitation is going to make many hospitals, I think especially private or smaller hospitals, to be reluctant to take a sample in the first place. Hospitals have their own labs, and probably many even have PCR machines, but because they're not approved for COVID-19, they have to ship a sample to another lab. As you can imagine, this creates logistical and administrative barriers, and frankly, I think hospitals are only going to test if they strongly believe that it's a case. It's also why widespread sampling and sentinel sampling is not occurring in Thailand. So let's consider the actual number of infected people sick with COVID-19. Imagine we actually knew who all those people are, and here they are at the top. But only a subset of them will have severe symptoms. Let's say that's about 20%. So of those severe cases, some might not present to hospital. They don't want to go. Others might go to the hospital and not get tested due to the barriers I mentioned. So let's say that's about 80% of the severe cases get tested. Then we see that based on methodologies and the lab protocol, some of those tests will come back false positive. So maybe only 75% of those tested who are actually infected will come back positive. And that's the sensitivity rate. And remember, I said that some estimates say this could be as low as 60%, but I'll be generous here and say that it's 75%. And you can see that we would miss a lot this way. And let's put numbers to it. So in Thailand, we currently have 42 confirmed cases. If we divide by 75%, we could say that 56 people were tested who actually had the disease. And if we divide by 80%, we could see about 70 severe cases. And if we divide by 20%, we see 350 actual infected people. Now, this is just a hypothetical exercise, but I'm using very possible estimates here. The bottom line is that based on the standard practice and the uncertainties in our methods, we should expect that many infected and minimally symptomatic people are out there, and that the confirmed cases is just the tip of the iceberg. Okay, so that's it for today. Thanks for watching. If you enjoyed today's video, let me know in the comments. I read them all and respond if I can. I'll see you next time.